Dear colleagues, ladies and gentlemen, let me start by welcoming our panelists of this session. We have Kendra Grubb and Adam Greenbaum from Atlanta, Georgia, in the United States. And we also have Giuseppe Tarantini from Padua in Italy. Today, it is my distinct honor to introduce our keynote speaker. Our keynote speaker is an undisputed professional hero of mine. He is the medical director of cardiothoracic surgery for the Baylor Scott and White Health System, and also the chairman of the Baylor Scott and White Heart Hospital. He was the president of the Society of Thoracic Surgery and is now the chair of the American Board of Thoracic Surgery. And his research accolades are nothing less than impressive. As a cardiac surgeon, he was critical for several defining pivotal randomized controlled trials, such as the Syntax trial, the Partner family of trials, the COAP trial. And those trials are still the foundations of contemporary guidelines for coronary revascularization and valvular heart disease. So let me present to you Dr. Michael Mack to give the 2024 TIO keynote lecture, which will feature his surgical perspectives on transcatheter structural interventions. Dr. Mack, the floor is yours.
Thank you very much, Nicolas, and thank you for that overly kind introduction. All that really means is that I'm really, really old. And Nicolas, I want to remind you to be very nice to me in the question period afterwards, because there are 9 World Cup games occurring in Dallas. So if you're nice to me, we'll figure a way to get you here. This is my conflict of interest disclosure. As Nicolas mentioned, I've been in the leadership of a number of trials in the structural heart space. The outline of this presentation, I'm going to give you my perspectives as a surgeon on aortic, mitral, and tricuspid transcatheter therapy. If we start first with aortic, it's hard to believe, but it's actually been 36 years since the original idea came for a transcatheter aortic valve by Anderson in 1988. It seems like a tsunami that's happened in the last decade, but the first implantation was actually done in 1989. It's culminated in this 5-year outcomes in low-risk patients in the New England Journal of Medicine in November, and I'll summarize the finding as follows. SAVR was better at 5 years in terms of paravalvular leak and valve thrombosis. TAVR was better for periprocedural atrial fibrillation and serious bleeding. Everything else was exactly the same. Mortality, CV death, non-CV death, stroke, disabling stroke, rehospitalization, valve hemodynamics, structural valve deterioration, and quality of life. But there's a key concept here that in American baseball, a tie goes to the runner. Anytime we do a procedure, the less invasive procedure beats the more invasive procedure. So a tie is good enough for a less invasive procedure. In other words, it only has to be non-inferior to be the preferred treatment for patients and their referring physicians. For a more invasive therapy, it has to win. It has to be superior in order to be clinically widely adopted. Now, the only thing to keep your eye on in the partner trial is all-cause death. And the yellow is surgery and the blue is TAVR. And you can see there was an early mortality advantage at a year to TAVR. Those lines crossed at 3 years, and now at 5 years, there's an almost 2% mortality advantage to surgery. It is not statistically significant, but those lines are diverging, and it's only speculative as to what happens from here, but there will be follow-up at 7 and 10 years. So if we look at what's happened with TAVR, since commercial introduction in the United States, there's been a 25-fold increase in the number of transcatheter procedures performed in the ensuing decade, such that now 85% of all isolated aortic valve replacement in the United States is done with TAVR. The good of all this is that there are twice as many patients with aortic stenosis being treated at the end of the decade as there were at the beginning of the decade. So who are those 15% of patients who will still have aortic valve surgery and not TAVR? Well, there are patients with aortic stenosis, mainly young patients, and bicuspid valve, which I'll talk about in a minute, aortic regurgitation, ascending aortic aneurysm, endocarditis, and the most rapidly growing surgical procedure, TAVR explant. So it should also be noted that the results of any trial are only applicable to the patients that are actually studied in that trial. So who was not studied in PARTNER 3? Well, patients under 65 years old. Only 9% of the patients in the randomized trials were under 65 years old. Bicuspid aortic valve disease was excluded. Concomitant disease needing treatment was excluded. Coronary artery disease not amenable to PCI was excluded. High-risk features for TAVR, and previous prosthetic valves, either SAVR or TAVR. So the results of the trials do not apply to these patient populations. Now, if we talk about bicuspid aortic valve for a minute, we know on the left that there are patients that are suitable for TAVR. We also know on the right that there are patients that are not suitable for TAVR and should undergo SAVR. However, where the yellow zone in the center remains to be defined. So that is going to be the subject of some upcoming trials. As baseline of this is published in January of the current outcomes of aortic valve disease in the United States with surgery. And there are 200,000 patients treated, of which 55,000 are bicuspid aortic valves. If we look at the overall operative mortality of bicuspid aortic valve in green, it is 1.2%. So that is the bar that we'll be looking at in trials going forward. So there are 3 proposed trials of bicuspid aortic valve. One called the Navigate trial by Stefan Windecker and Matthias Seppi of bicuspid valves over 60 years old. Raj Makkar has submitted a trial, the Believers trial of bicuspid valves in patients over 50 years old. And Myra Guerrero has proposed the Young TAVR trial of all patients 50 to 65, independent of bicuspid or tricuspid valves. I think in younger patients, we shouldn't forget mechanical valves. There are multiple series. This one is from Sweden, but there's multiple series in the literature that shows survival over 15 years is significantly greater with mechanical valves than tissue valves, despite the need for anticoagulation. And we now know we can use lower levels of anticoagulation than previously. Also, there's renewed interest in the Ross procedure. There are increasing numbers being performed in the United States and increasing centers performing these adequately. This is the only valve intervention that restores normal life expectancy to a patient with valvular heart disease. So reasons why SAVR and not TAVR in bicuspid disease. Well, one is bicuspid wasn't included in any of the trials. There are anatomical difference. TAVR has acceptable one-year outcomes in very highly selected patients. TAVR has higher rates of stroke, pacemaker, and PVL in bicuspid compared to tricuspid disease. As I mentioned, the surgical mortality is 1.2%, and the stroke rate is 0.75% in all patients with bicuspid disease. The Ross procedure and mechanical valves should remain to be considered as an option, and we do need a randomized trial. I thought the window had closed, but it looks like at least one of these will happen. Now, how about concomitant conditions with aortic stenosis that mitigate toward surgery? I think you should make the decision based on the management of the concomitant disease. So concomitant conditions with aortic stenosis that would lean towards SAVR rather than TAVR, high syntax score coronary artery disease, mitral regurgitation, especially primary MR, tricuspid regurgitation, because we know patients with TR don't do as well with TAVR as patients without TR. Now, all of this may change with impending approvals of tricuspid valve interventions in the United States, ascending aortic aneurysm, and atrial fibrillation if a MACE procedure would be performed at the time of surgery. Now, as I mentioned, TAVR explant is the fastest growing surgical procedure. The mortality has been high. There are multiple surgical techniques now of how to explant these valves. I think that summarizing the role of surgery is that TAVR will not go away. There will be the same proportion of surgical procedures versus TAVR as CABG versus PCI. And that'll be somewhere in the range of about 3 to 1. So 3 TAVRs for every SAVR. SAVR will be more complex, including root enlargement, TAVR explants, Ross procedures, Bentals for ascending aneurysms, et cetera. Multivessel disease, multi-valve disease is surgery for now, but will be the focus of near-term future trials. And we will see a bicuspid aortic valve trial in the future. So moving on, I would submit that TAVR was a lightning strike. And the question is, will lightning strike twice or 3 times in mitral and tricuspid disease? And I'm skeptical that it will. I think that expecting a deja vu all over again with mitral and tricuspid, the same as TAVR, will probably not happen. So let's look at the tale of 2 devices, TAVR and TEER. We can see that I showed the timeline of TAVR. You know, the timeline of TEER is not that different. And the first human of TAVR was performed in 2002. The first one in TEER, it was in 1 year later in 2003. And look what's happened in that time frame, in the time frame since then. So this is what's happened to TEER in the United States. There's been a 12-fold increase since its introduction in 2014, from 1,200 to 14,000 procedures. And that seems good, but if you look at the proportion of all mitral valve treatment, the one on the top is all surgical mitral valve procedures. In the center is isolated, and in the bottom is TEER. So unlike TAVR, the number of transcatheter procedures has not surpassed those of surgical procedures. And if you look at the comparative increase in the number of procedures of TAVR versus TEER, there are still 7 times greater number of TAVRs performed than TEER, despite an only 2-year difference in the time of introduction in the US. So why has the adoption of mitral TEER not been as great as TAVR? The principles of adoption of any new procedure or device are, if you gotta have a robust evidence base, it has to be user-friendly, and it has to be teachable. And TAVR met all of these in spades. Well, what about mitral TEER? Well, there's been slow evidence generation, and the benefit has not been as clear on the basis of the 3 trials that are well known in functional MR. It's not as user-friendly as TAVR. The imaging requirements are greater. The procedure times are longer. And there's only about half as many TEER sites as TAVR sites in the United States. It's more difficult to treat, and it's not a single disease. There's a spectrum of primary MR, and then there's secondary MR, which now we realize there's actually atrial and ventricular MR. So let's look at primary MR first. This is the results of primary mitral regurgitation in the United States. The median mortality of all mitral valve isolated operations in the United States is 0.43%, with a 90% of the patient's risk is under 1.6%, with a greater than 95% correction of mitral regurgitation. If we look at TIR mortality in the United States, and granted, these are not comparable patients because they are different risk, the TIR mortality at 30 days is 3.3% in the United States, but that includes both primary and secondary. This is a report from Raj Makkar looking at transcatheter mitral valves for primary MR, and we see that the mortality rate is 2.6%. Unplanned cardiac intervention is 1.7%. Stroke is 1.4%. And again, these are not comparable populations because the patients were intermediate or higher risk treated with transcatheter, but it does show the baseline of where we're at right now. Also from this series showed that leaving a patient with moderate MR was an independent factor for mortality, even at 12 months. So the role of mitral TIR in low-risk patients, there are clearly pros and cons. Risk creep is occurring in part due to patient preference. Equipoise now exists for randomized trials, and there are two currently randomized trials that will inform clinical practice. One is the primary trial sponsored by the NIH in the US, that is an all-risk patient. 75% of patients enrolled in the trial are low-risk patients, over 60 years old. It's a superiority trial design. All patients will be followed for at least 3 years, which means the median follow-up will be 5 years, and all patients will be followed for 10 years. The Repair MR trial is sponsored by Abbott. It's intermediate risk, 500 patients, non-inferiority trial, and will also be followed for 10 years. If we look at secondary mitral regurgitation, we're all familiar with the COAPT trial and the results of the COAPT trial that showed that the number of patients needed to be treated to prevent a hospitalization was 3.1, and that there were a number of patients needed to be treated to prevent a mortality was 5.9. Astronomical, fantastic results. However, there's been significant evolution of medical therapy since that time. And the 4 pillars of contemporary guideline-directed medical therapy of beta blockers, SGLT2 inhibitors, ARNI, and mineralocorticoid antagonists were not widely used in the trial. Sacubitril valsartan was used in only a few patients at the end, and SGLT2 inhibitors had not been introduced into clinical practice. We also know this is the result of our center of looking at optimal treatment of guideline-directed medical patients with severe MR, and about half of those patients resolved to mild MR or less just on guideline medical therapy alone. There's this important publication by Adamo that looked at the results of patients that treated in clinical practice that looked like the patients in COAPT and those that didn't, and showed that there's a significant of freedom from mortality and freedom from heart failure hospitalization if you met the COAPT criteria versus if you did not. And that's shown on this slide. This is the results of the COAPT trial, 2-year mortality, device arm in purple, in maroon, control arm in blue. And as you can see, if you were on the right, you had non-COAPT-like symptoms and were treated, you were no better than medical therapy in the COAPT trial. So I think that the following can be summarized: that the COAPT trial showed a benefit to the addition of TIR to guideline-directed medical therapy at 5 years. However, guideline-directed medical therapy has changed significantly since COAPT. New TIR devices and more informed patient selection may improve outcomes. However, it's felt that the results of COAPT may not be applicable today due to the evolution of medical therapy. There's a question, should the COAP trial be redone again, and would it still win? I think the only thing we can say for sure is the COAP trial took 6 years to enroll. Today, it would take 12 years to enroll due to better medical therapy. And the heart failure community remains unconvinced of the benefit of TIR in addition to guideline-directed medical therapy. So if we turn quickly here at the end to tricuspid regurgitation, we know that 90% is secondary, most is ventricular, increasingly recognition is atrial. For functional mitral regurgitation, surgery is most commonly an annuloplasty that takes the dilated annulus and cinches it down, sparing the area of the AV node. This is a patient undergoing robotic tricuspid valve repair, showing a competent tricuspid valve after an annuloplasty being placed. This is a patient with the lead-induced tricuspid regurgitation. You can see the posterior leaflet of the mitral valve having the lead incorporated into it, and that's a fairly straightforward valve repair. So the role of surgery in tricuspid valve disease is about half of patients are endocarditis, lead-induced, patients that are not candidates for transcatheter therapy, tricuspid stenosis, and tricumbent disease. There will be a paper published shortly that shows that there are currently now about 2,000 isolated tricuspid valve operations performed per year in the United States, and the overall operative mortality is 5%. Much better than we were led to believe from previous series. Transcatheter valve devices in trials, there's a whole plethora of them. They're divided roughly into repair and replacement. These are the devices in the United States. This is Triluminate trial at 1 year that showed that it was safe, but there was only improvement in quality of life, and that about half of the patients in the trial are left with moderate or greater residual that should be TR. But with these findings of only a quality of life benefit, the FDA panel voted in favor of TriClip for tricuspid regurgitation, and it's expected any day now that the FDA will actually approve it in the United States. The transcatheter tricuspid valve replacement is a wide open field. This is the EVOQUE trial, which was the first one completed in the United States. The results have not been published yet, but this is the data that's contained in the FDA label that shows that there is a trend toward a mortality benefit at 1 year, despite the fact that there was a higher early mortality due to the procedure. And there was also significant improvement in quality of life as measured by KCCQ, New York Heart Association, and 6-minute walk. It was on this basis that the FDA approved the replacement without a panel. So the summary of transcatheter tricuspid regurgitation is tricuspid TIR is safe, but I would question how effective it is. Transcatheter valve replacement is effective, but it's not as safe. Replacement with EVOQUE is now approved in the U.S. TIR is expected to be approved any day, but both are not reimbursed yet in the United States, but they have what's called a breakthrough device designation that supposedly will lead to early reimbursement and a national coverage analysis by Medicare in the United States. So to summarize, Donald Rumsfeld, the American Defense Secretary, there are known knowns, there are unknown knowns, and known unknowns and unknown unknowns. For tricuspid disease, the known knowns are that TR is bad, it has a bad prognosis with no effective medical therapy, and it's now more commonly operated on by surgery than previously. The known unknowns are we really don't know the prevalence, rate of progression, the definition of futility, how the right ventricle will respond, because the right ventricle gets worse after replacement, at least temporarily. Unclear that correction changes the prognosis, although now there's an early signal in EVOKE, and is improvement in quality of life sufficient? The unknown unknowns are we're going to learn a lot about in the time course of management of TR by the transcatheter approaches, since now a significant more number of patients will be treated. So the history of cardiac surgery is staying one operation ahead of extinction. It started with tuberculosis, rheumatic fever, arrhythmias, on down the line, and you can see that each of these threatened to put our specialty out of business, but it survived 100 years, and I think it'll survive transcatheter valve therapy also. So thank you very much for the opportunity in making this presentation.
Thank you very much, Michael. That was a very holistic, but also a very cool overview of what has transpired over the last 20 years in the setting of transcatheter valve therapies. And I had a very important takeaway from a trialist point of view, where you made a clear statement that, you know, when you compare a less invasive with a more invasive technique, non-inferiority would be enough for the less invasive strategy, but you would need superiority for the more invasive strategy. And I think that is a very important concept that we need to also embrace as a community. But I do have a question for you now. Obviously, you are a pioneering surgeon. You embraced the concept of transcatheter therapies at a very early stage, well ahead of the curve. But how is the situation now in the United States in terms of transcatheter structural training for the cardiac surgery curriculum? Is it now mandatory or is it still optional?
It is, well, you know, first of all, you know, I did adopt this early. I suffered, I'm old enough, I suffered through all the CABG versus PCI wars, and I saw how that turned out. And it wasn't hard to connect the dots and figured out what was going to happen here. The first time I saw a TAVR procedure in an animal in the late 1990s, it wasn't hard to connect the dots. So from my experience of seeing how a surgery versus PCI turned out, I felt that I kind of could figure out what was going to happen here, and I could either ignore it, I could fight it, or I could join it and be a part of how this rolled out. I must say that with the exceptions of people like Kendra, Isaac George, Gaurav Alawadi, Rob Smith, and some Catherine Harrington, the adoption by surgeons has not been as great as I would have hoped. It is part of mandatory training in the United States. There are requirements for participation in TAVR procedures, both as secondary and as primary operators in order to obtain your board exams in the United States. But I think, like politics, all practice is local, and there are situations in which heart teams function extremely well, like the group at Emory. But there are others in which, you know, the heart team is a checkbox, and participation by all members is not nearly as optimal as you would hope.
Adam, so good to see you, by the way. It's the first time I see you in a panel now, and hopefully more in the future years as well. Question for you. Today in the United States, when a TAVR procedure is being done, is it still mandatory to have the surgeon involved in the procedure? How does it go in the United States now?
It is in the United States, due to reimbursement-related regulations, it is still being performed in combination with the surgeon and an interventional cardiologist together, not just in the hospital around if there's a problem, but in the procedure together. Maybe different from, you know, from the rest of the world.
Oh yeah. And do you think that is gonna last, or do you expect that this situation will change over time? Because obviously, from a technical point of view, it's maybe not really necessary to have the surgeon in the room.
Sure, although in the United States, nothing will change until there is a re-evaluation and re-review of the reimbursement strategies. And that only occurs every few years. And Kendra may know, and Mike may know when the next review would be, but it's probably not for a number of years, correct?
Yeah,
Michael?
I agree with that, Adam. The reimbursement coverage was reopened last, I think, in 2018 or 2019, and it's unlikely to be opened again. So, I mean, you can do anything you want, but not if you want to get paid for it. So that's a pretty strong, it's either a carrot or a stick, whichever you want to call it, but it is a pretty strong motivation to kind of keep things as they are.
Mm-hmm. Giuseppe, Michael clearly identified bicuspid aortic stenosis as one of the next big trials that is laying ahead of us. Do you agree with that, or are you expecting another trial that needs to be done in the context of aortic stenosis?
Yeah, I fully agree with the presentation of Adam. Actually, related to the bicuspids, the situation is different all around the world. Because, for instance, I was last month in China. In China, 40% of bicuspid are type 0. That means that the outcome with type 0 is pretty much the same as tricuspid, because you don't have raphe, you don't have, anatomical situation that's make difficult and also may impair the long-term outcomes of these patients. So bicuspidity, I think it depends on the prevalence. And actually, as I told you, in China and the eastern region is more prevalent than in a Western country, and also the type of bicuspidity that is totally different. But actually, going back to the lecture that has been really spectacular of Adam, for me, I have just two things that I would like to ask to Adam. I think I see some difference compared to the PCI in CABG, because first of all, we cannot use the wording mini-invasive for TAVR, because TAVR is not mini-invasive, it's a mini-access. It is a total different concept, at least for what I think, because we don't need general anesthesia, we don't need to have any scar, we don't have CPS and so forth. So this is mini access. And the other point that is make difficult to replicate what we have seen with PCI and CABG is that PCI was a distinct field of action of interventional cardiologists, but for TAVI it's not like that, because as you told us, but also in Italy, actually, we have a mix-up procedure. To be honest, it's very difficult to melt the two specialties, because we have some centers where there are surgeons that perform directly the TAVI, and others where only interventional cardiologists perform the procedure. So I think it's very difficult to replicate what we have seen with PCI. I don't know, Adam, what you think.
And Michael, you need to understand, Giuseppe, when he says Adam, he means Michael. So that is a question for you.
It's my mistake, pardon, my mistake.
No worries, but I'd love to hear Adam's thoughts here.
Well,
go ahead, Adam.
Okay. I guess, yeah, these are my thoughts, but the comparison of PCI to CABG, to me, is a different one, because actually they never did the same thing, right? This whole concept of you were bypassing the whole vessel versus you were spot stenting one area of trouble. I think that the question is, can the structural procedures, although there will always be some differences, can they more mimic surgery as opposed to this fundamental difference between PCI and CABG? For instance, sure, we leave the leaflets behind with TAVR as opposed to surgery, but it's a lot closer. Do you not agree? Yes, MitraClip doesn't provide an annuloplasty ring, but there is good data that the AP dimension is reduced. And of course, it mimics the alveoli stitch, right? A tricuspid replacement is very similar to a tricuspid replacement. So, and the structural procedures, although they will always be subtle differences, are they closer, and therefore is the argument not the same? Is that, what do you think about that?
I think I totally agree with and those comparisons, Adam. And I think Giuseppe said it well, that rather than minimally invasive, minimal access, I think is the appropriate way to consider it. Kendra, you do both. What are your thoughts?
Well, I think the one part that we're neglecting is that what does the patient want? And the hard part right now is that, especially when we're discussing TAVR, the results are so good and so comparable to surgery, at least out to 5 and in some cases 10 years, in lowish risk patients, youngish patients, that the patients are informed and they want that. And I think that we will continue to see evolution of the devices. You're already seeing next gen devices, and they'll be even better than what we have. So for TAVR, I do think, since one of the questions was, do we think that we need the surgeon still? Well, I think you need an operator that's going to be able to give a good result that mimics surgery, that's conscious of all of the possible complications. So they're thinking of commissural alignment, they're thinking of coronary reaccess, they're thinking of pacemakers, PVL, all of those things at the time of the procedure. And so that takes a much bigger commitment to investing in the pre-planning. And whether that's a surgeon or an interventionalist or both, it's really what our patients expect right now.
Nicolas, can I make a question to Michael?
Sure, yeah.
Yes, and for all the panelists. So who you think has to be the comparator of TMVR? Should it be the TEER? Should it be surgery? What? Because I think that for primary mitral regurgitation, surgery is unbeatable. So actually, I don't understand who is going to be, in perspective, the real comparator for TMVR, and actually who is the right patient selection to perform it. Because for me, what is not clear, if we deal with the secondary mitral regurgitation and surgery is contraindicated because of the risk of the afterload mismatch, actually this risk remain with the transcatheter approach. So for me, I'm a little bit lost in this regard. So for me, it's important to hear from Michael and Kendra and you all.
Well, I think that one of the things we have to demonstrate first is that TEER has long enough durability. And I think that Dr. Mack's presentation highlighted that you have to take the two types of mitral regurgitation as separate entities. And so you may find that TEER versus surgery is appropriate in younger or lower risk primary MR. But for secondary, Giuseppe, you're absolutely right. There's not a great surgical precedent. And so that might not be the right comparator in that regard. And so then going to TEER may make more sense in those trials.
I was referring to TMVR.
Right, and I understand that, but we don't have a TMVR device now that's shown any durability or safety yet, and so we're so far behind. I guess what I'm saying is that first we have to demonstrate that the safe procedure that is efficacious matches up to the repair techniques, then go into the replacement. In my presentation on Monday that kicked us off, I said, a surgical dogma, and Michael Mack, please jump in here, a good mitral replacement is better than a mitral repair. Excuse me, a good mitral repair is better than a replacement, which is better than a bad repair. And the question becomes, is TEER or TMVR going to match up in that hierarchy? Michael?
No, totally agree with that statement, Kendra. There was a trial of functional or secondary MR done in surgery in the early teens. And that result showed that replacement was better than repair. However, the caveat that was those patients that got a good durable repair are actually the ones that did the best. And those were patients without inferior basal aneurysms and without extremely dilated ventricles. However, to answer Giuseppe's questions, I mean, the randomized pivotal TMVR trials in the United States are versus TIR. So that is the comparator for mitral that's being used in the trials in the US right now.
But
All
mostly
right.
for
With that, I
secondary
think,
MR, right?
well, yeah, that's true. Secondary MR for TIR. But okay, I think we have to move on in the interest of time because we have one more presentation and then we'll move to some live cases. So Michael, please stick around for some more panel discussions. But first I want to launch a poll here for the audience. And the first question that we wanted to ask is, okay, so we've now talked about potential bicuspid trials, but there is also other trials that are being done and are will be presented later this year. And one of the randomized trials will establish TAVI for symptomatic moderate aortic stenosis. Well, what do you think? Is that yes, this trial that evaluates TAVI in the context of moderate aortic stenosis, is that going to be a positive trial? Or do you think that it just doesn't make sense and we should not be treating moderate aortic stenosis? So the question to the audience, what do you think? Is that going to be a positive study or a negative study? So take some time to digest, and in the meantime, we also want to have a second poll question, and that is, there is also a randomized trial evaluating TAVI or TAVR in the context of asymptomatic severe aortic stenosis. So what does the audience think? Will TAVI or should TAVI become the default strategy for asymptomatic severe aortic stenosis? And here, the responses can be either yes or no. SAVR, surgery, should be the default strategy for asymptomatic severe AS, or do we need a randomized trial comparing TAVI with SAVR, or none of that, only watchful waiting for asymptomatic severe aortic stenosis? And that brings me then to the next talk, the next presentation. So we will come with the results of the polls after that presentation, but now I want to give you a presentation on my predictions of the outcomes of the upcoming Upstream TAVI trials. All right, so I do have some conflicts related to this space. Basically, if we look at aortic stenosis, then there is a recent publication from Philippe Généreux in JACC, where he had an enormous data set of more than 1 million patients. Over 500,000 patients of that million did not have a severe aortic stenosis. And then almost 71,000 patients had some kind of diagnosis of aortic stenosis. And then obviously they separated mild to moderate, moderate to severe, and severe aortic stenosis. And what was interesting in their outcome is that if you look at rehospitalizations or hospitalizations, then obviously the patients with severe aortic stenosis really had a lot of hospitalizations. At 5 years, 60% of the patients, 1/3 of the patients with moderate to severe aortic stenosis also had hospitalizations. And then when it really becomes low to moderate or low to moderate, then the hospitalization rate was only 10%. But if you look at mortality, there is a different reality. The mortality of moderate or moderate to severe aortic stenosis basically was almost overlapping with the mortality of patients with severe aortic stenosis. And I think this really is in keeping with recent thinking of moderate aortic stenosis, that it is not maybe as trivial as we want it to be. And obviously we are familiar with the guidelines. In principle, we wait for the aortic valve to degenerate and become severely stenosed before we would consider valve replacement based on contemporary guidelines. But the question is, should we not interfere somewhat earlier in that time window of degeneration? Because when a valve is degenerating, things are changing with the muscle part, if you will. And there is this process of maladaptive cardiac remodeling that basically results in irreversible fibrosis. And once this irreversible fibrosis is more extensive, well, then it will have an effect on early mortality, but also heart failure and poor quality of life after valve replacement. So basically what you want to do is, if we look at cardiac mechanics, you want to prevent this transition from a pressure overload condition to a volume overload condition, because when it's volume overloaded, that means that the ventricle really has transitioned to maladaptive cardiac remodeling, and that will become irreversible. And this is obviously where a lot of thinking has gone into the concept of treating moderate aortic stenosis or asymptomatic severe aortic stenosis. And this is data from our group here in Rotterdam, where we started a multi-center collaboration and identified more than 300 patients with heart failure and reduced ejection fraction and moderate aortic stenosis. Well, it turns out that these patients have a lot of clinical events. So 2/3 of those patients had an event within 4 years, and the mortality rate was at least 10% every year and every subsequent year. So basically, these patients with moderate aortic stenosis and heart failure, well, they seem to be vulnerable, and even more vulnerable than patients with heart failure and reduced ejection fraction with no moderate aortic stenosis. And this is another trial that where we collaborated with our friends in Quebec and looked and compared and did a propensity matched analysis comparing patients with HFrEF and no AS with HFrEF and moderate aortic stenosis. And it turns out that moderate aortic stenosis results in a dramatic increase on top of the existing mortality and need for hospitalizations in these HFrEF patients. And then obviously you ask yourself, okay, what would happen if we would treat these patients? Well, we did another analysis where we looked at patients with established moderate aortic stenosis and for whatever reason ended up having a TAVR procedure. And then we did again a propensity matched analysis of patients with established moderate aortic stenosis but had a watchful waiting approach. And it turns out that patients who received a TAVR valve definitely did better in terms of overall survival, predominantly driven by cardiovascular survival. So that is, I think, an important insight that maybe also justifies this concept of randomized controlled trials for patients with moderate aortic stenosis. And we have 3 randomized studies. One is the TAVR Unload, the other one is Progress, and then there is also the Expand 2 randomized controlled trial. On the 2 trials on the right, Progress and Expand TAVR 2, they don't make any distinction in terms of ejection fraction. The TAVR Unload specifically focuses on patients with heart failure and reduced ejection fraction. And the news here is that the TAVR Unload trial completed its enrollment last year in January. So we have our full data set complete in terms of 1-year outcomes, at least 1-year outcome this year, and we will present our results at TCT 2024 later this year. The other news is that also the Progress randomized controlled trial already completed its enrollment last December, and so first results are expected to be presented in 2026. So let's move from moderate aortic stenosis to asymptomatic severe aortic stenosis. There 2 randomized controlled trials that already looked into the value of valve replacement for asymptomatic severe aortic stenosis. And the first one is the Recovery randomized controlled study. That was a study run in South Korea that was comparing surgery with a conservative watchful waiting approach. The median follow-up was 6.2 years, and it turns out that surgery really outperformed a watchful waiting approach in terms of mortality and also in terms of rehospitalizations or need for hospitalization. So clearly the mortality was lower in the treatment arm and also fewer hospitalizations. Another interesting aspect of that study was that 3/4 of the patients that were randomized to the control arm eventually underwent valve replacement, aortic valve replacement, and the dominant reason for the valve replacement was the development of symptoms and obviously the transition from moderate to severe aortic stenosis. Another randomized controlled study was the AVATAR trial. This is a trial that was performed in 7 European countries, again comparing surgery with a conservative watchful waiting approach. Median follow-up was not as long. It was only half of the follow-up in the recovery RCT. And if we then look at the primary MACE endpoint, again, the invasive therapy, aortic valve replacement, outperformed the watchful waiting approach. But if we then focus on mortality, there was no longer a difference between the two treatment strategies, probably because the follow-up duration was not long enough, because you see that the curves are separating more and more over time. Again, also 40% of the conservative treatment group eventually underwent aortic valve replacement. So we have 2 big randomized controlled trials on this topic. There is one, the early TAVR trial, and then the other one is the EVOLVE trial. The EVOLVE trial is a little bit special because it also introduced cardiac magnetic resonance, so MRI, to demonstrate fibrotic or the occurrence of fibrosis in the myocardial tissue. And then patients are randomized to either a valve replacement, whether it is surgical or transcatheter, or watchful waiting approach. The other one is the early TAVR trial, and that compares basically TAVR or TAVI with a watchful waiting approach in patients with proven asymptomatic severe aortic stenosis. And also that trial has completed its enrollment and will be presented at TCT 2024. So in conclusion, I think that any degree of aortic stenosis is now clinically relevant, or should be considered clinically relevant. We have randomized controlled trials that are evaluating Upstream TAVI, and Upstream TAVI is either moderate aortic stenosis or asymptomatic severe aortic stenosis. And if we then focus on the TAVR Unload trial, the trial that will be presented on moderate aortic stenosis later this year, my prediction will be that this is going to be a positive trial in favor of an early invasive upstream valve replacement therapy. And if we look at the early TAVR trial, I think here I have a little bit more doubt. But at the end, if you want my prediction, I also feel that that trial is going to become a positive study. With that, I think we can go back to our panel. But first, it's maybe interesting to see the results of the poll. So let's bring up the results of our first poll question. So do we feel that the randomized controlled study will establish TAVI for symptomatic moderate aortic stenosis? And wow, I think our audience is convinced that TAVI for moderate aortic stenosis makes a lot of sense. I still, well, let's get to the panel in a second. And let's go to the next question. The next question is, what do we feel about asymptomatic severe aortic stenosis? Well, here we have a little bit more variability. Almost 50% feel that we need a randomized controlled trial comparing TAVI with surgery. That is interesting. And then 32% says, yes, TAVI should become the default strategy. Well, this is interesting. Maybe, Michael, what do you feel of this last poll result? Do you also believe that we need a randomized study in asymptomatic severe AS patients comparing TAVI with surgery?
So I'm not sure that that is the case. I think that we do have evidence that surgery is beneficial, at least in very severe aortic stenosis. I think if the early TAVR trial is positive, then TAVI has demonstrated the same, and I'm not sure there's a reason to do a randomized trial. The only caveat or concern I have about this, even if early TAVR is positive, is that by doing an early replacement when the patient is asymptomatic, there are clearly benefits because there is an incidence of sudden death on observation only, and we know that myocardial damage does occur before placement. But we're not curing a disease. we're curing a native disease and replacing it with an iatrogenic disease, and that's bioprosthetic valve. And I think of this like heart transplant. You never want to start the clock until you actually have to, because you know a transplanted heart has limited durability. It's going to wear out in 12, 15, 20 years. And so why start that clock before you absolutely have to? I think the same thing here. With TAVR, you have limited durability. And do you really want to start that clock before you have to, even though you can do valve and valve, et cetera? I don't think you can use the analogy of we treat asymptomatic mitral disease with surgery, because we're not leaving a prosthetic valve behind. You know, we're curing a disease for the most part. So even if early TAVR is positive, that's my concern, that should we really be starting that clock earlier than we have to?
Wow. Yeah, I think that is spot on, I feel. And I'm totally in line with that line of, way of thinking. Let's briefly talk about moderate aortic stenosis. Adam, how important do you feel ejection fraction is in this discussion? So basically we have two trials that don't look at ejection fraction, and then TAVR Unload specifically looks into patients with reduced ejection fraction. Do you feel that this ejection fraction might be a driver of the outcome for TAVR?
I do. It may affect the outcomes of the trials, but if you take the durability issue aside, right, meaning putting them in too early, I'm in the camp that we need to move earlier for all of these. I mean, I just don't think any of the remodeling that occurs can be good. And so whether your ejection fraction is still preserved, right, if we can offer a safe enough procedure with good durability, I don't know why we wouldn't move earlier on both. So it may affect the outcomes of the trials, but I think in the end, for the benefit of the patient, it's probably independent of ejection fraction. If I had moderate aortic stenosis and preserved EF, I'd still want a TAVR if you could tell me it was going to last.
Yeah. So basically, you are following the cardiac damage concept, right? You want to be ahead of the curve. Kendra, is this also your take on this?
Well, maybe I've listened to Adam too much in Heart Team, but we're totally aligned on this one. I totally agree that there's no reason to wait for you the ventricle to change, for there to be myocardial damage that may or may not be reversible. And certainly moderate aortic stenosis, we treat surgically. And so if we're there for another reason. So I just think that with the data we have, there's good reason to treat asymptomatic and moderate aortic stenosis. I wish we had longer durability data, then we could reassure our patients. But I think that the risks are high enough that we should intervene.
So Giuseppe, maybe a short question for you. Do you feel that, are you already treating moderate aortic stenosis, and do you feel that we are already ready to change guidelines, or do we have to wait the results of the 3 randomized studies?
Is it for me?
Yeah, there's one Giuseppe, that's you.
No, I haven't heard Giuseppe. So actually what I think is that I'm not treating moderate aortic stenosis, but going back to the general discussion, it is changing the trigger point of intervention. This is the title of this session. So actually I'm very positive to the, to the thinking that treating moderate aortic stenosis might be worthwhile. We need longer follow-up, because actually it's what we do with Entresto. We want to reduce the, by Laplace law, we want to reduce the afterload in this failing, heart. So actually getting rid of these gradients for sure is helpful in terms of mechanical energetic of the ventricle. So I'm very positive. We need a longer follow-up. I'm a little bit more in doubt related to the asymptomatic patient, and I'll tell you why. When you compare, the early TAVR with the recovery trial, sometimes, in really few meetings, I've heard, the mean age of the treatment of the patients. Because in the recovery trial, the mean age was 63. That is absolutely not the mean age, won't be the mean age of the early TAVR. So actually, the surgeon were able to reduce the sudden deaths from 18% to 4%. And this was related to the mean age of the patient that were treated. When we treat patient by TAVR, actually, they're going to be more than 75, at least in Europe. So it's very difficult to consider in a 65 years old to go for TAVR in asymptomatic patients. So if in the early TAVR, I want to looking forward to the result, but if the mean age is 80, and actually based on the recovery, the effect was visible at 1 year, but mostly after 8 years, I'm not sure that we will see the same results.
I agree with you. All right, with that, I think we're coming to the end of the first hour of today. I think this was a very inspirational session, and thank you very much, Michael, for these valuable insights, and also thank you to the panel for a great discussion. So now let's move to the Cath Lab here in Rotterdam, where Joost and Herrier are ready for the first case, and then we will switch from Rotterdam to Copenhagen in 10 minutes or so. So first, can we go to the lab in Rotterdam?